Okay, we're going to go ahead and get started. Hello, everyone, and welcome to another session of the Virtual Global Spine Conference. It's really a pleasure to be here today to present on this topic. And as you know, I'm one of the co-hosts. I'm very lucky to be working with a wonderful team that many of you have gotten to know over the months and years. And it's really a really nice treat when we get to present when we actually get to present too. So thank you all for being here. This session is going to focus on some cervical spine pathology. It is an area of interest to me, both degenerative disease and deformity, but really cervical spine pathology in general. And I'm going to share some case examples, talk about some principles. Some of this will be, of course, review to many of you expert physicians and surgeons who are in the audience today, but hopefully we'll all be able to say we learned something new. So again, thanks very much for being here. Feel free to put any questions in the chat box, and I'll try to get to it at the end. So when it comes to cervical spinal deformity surgery, this is really what I look at. As you know, the goal with basically all spine surgery is how do you achieve good outcomes that are safe, and how do you minimize complications? Specifically, when we're talking about rather challenging or high-risk surgeries, we really need to make sure that we are minimizing the complications. And if we do encounter them, how do we manage? So in cervical spinal deformity surgery, not unlike lumbar degenerative deformity, it's all about studying the parameters. Of course, after a thorough history and exam and ensuring that the indications are proper, it really uh, necessitates a detailed analysis of the imaging studies. Specifically, what are the focal parameters? What are we achieving focally in terms of decompression, in terms of realignment? But also, what are the global parameters? How does changing the alignment in the cervical spine or in the cervical thoracic junction, for example, affects the rest of the spine? This is very important when it comes to the occipital cervical region, which I will discuss later in the last couple of slides here. So once you understand the focal and global parameters, you want to look at the releases and the resections. Where do you want to release and where do you want to resect? Whether it's anterior or posterior, or sometimes, in fact, many times, it is a combination of front back or back front, etc. You want to employ adequate fixation with cervical spinal deformity surgery. Again, not unlike the thoracolumbar spine. This is not an area where you want to go short or you want to shave some levels. If it is in fact a deformity, a significant deformity, and I'll show you a complication actually of mine, where we try to get a little bit less invasive, and sometimes that's just not the right thing to do. So employing adequate fixation, and of course, ultimately achieving arthrodesis. We're not talking about motion preservation. We're talking about deformity surgery. We're talking about stabilization and fusion. So when we talk about defining the parameters, everybody here knows we really look at standing X-rays, and I'll show some examples. Upright X-rays, standing scoliosis X-rays. I put these parameters here on a CT scan just to make it easier to measure and to look at what we're actually talking about. But in full disclosure, of course, these parameters should be looked at under X-rays, standing X-rays, upright X-rays. But in fact, I will say, as many fellow surgeons know, it is extremely helpful to compare the CT or the MRI to upright X-rays, right? Because that automatically gives you an idea of the difference in alignment in somebody who is supine versus somebody who's loading their spine. And it gives you a sense of whether there is perhaps partial flexibility or rigidity in that sense. So very, very important to compare the supine images with the upright images. But again, what do we look at when we look at the cervical spine? Well, we look at the obvious things like the C2 plumb line, right? The SVA, the C7 plumb line. We look at the cervical kyphosis or lordosis, the neck tilt, and of course, the very, very important T1 slope. The reason the T1 slope is very important because it really tells you whether the pathology is mostly axia, it's mostly cervical, focal cervical, or is it a cervical thoracic junction? So the higher the T1 slope, the more you have to really look at the thoracic spine and the high thoracic spine, and that could indicate that you need to go longer with the fusion. So all of these parameters are very important. I really like the T1 slope in a lot of these because that's going to basically tell me whether this is going to be a degenerative cervical spine case versus cervical thoracic and even, long cervical thoracic, if you will. Um, you can get access to many papers that talk about certain values and certain goals. I would say that the cervical spinal parameters are probably not written in stone, if you will, and we certainly have a little bit less experience than we do with the lumbar and the sacropelvic parameters. But nonetheless, there are some parameters that we should look at in terms of the SVA being under 4 centimeters. Certainly looking at the lordosis parameters and the T1 tilt of about 20 degrees, 20 to 25 degree of T1 tilt really is going to guide us one way or the other. So there is some value to looking at those numbers. And when it comes to cervical spinal deformity, this is a case where a patient underwent a C1 to I think it looks like C7. And of course, they have distal junctional failure, they have kyphosis. And I always tell folks that the solution to cervical deformity, or really the solution to any spinal deformity, is not extending the deformity, right? Or if somebody has a complication, don't extend the complication. As in this case, the patient has DJF, which is, by the way, a very common theme in cervical deformity surgery. The issues are typically at the bottom and not at the top. So whereas when we do lumbar, we'll worry about typically PJF, PJK. In the cervical spinal deformity, we certainly worry about the top, but most of the issues are coming at the distal junction. So again, this is not ideal. These pictures here are not ideal. That's not what we want to do, which is what I call, again, extending the deformity. That's not really ideal. This is a classic paper written by Dr. Chris Ames and his team on the different types of osteotomies that are needed to correct cervical spinal deformity. I would say the reality is most of us employ 3 or 4 different types of resections. It is extremely uncommon to start getting into the grade, 6, 7, etc., unless you're doing total spondylectomies and en bloc resections for tumor. But a lot of us are employing and I'll show you some examples in a minute. Many of us are employing the most common strategies, including posterior column osteotomies, PCOs, in combination with ACDFs or corpectomies to really realign and correct the vast, vast majority of cervical spinal deformities. Again, really, really important paper here that has shaped our understanding of these types of corrections. A little shameless plug here for some of our work with some excellent research and clinical fellows over the years. This is a paper that we published on, putting all of these numbers and all of these parameters into something that's a little bit more user-friendly, if you will. So we looked at measuring the spinal alignment, outcomes, et cetera, with a practical guide. Again, going back to those numbers, you want to be less than 4 centimeters sagittally. You want to have a favorable T1 slope, et cetera, et cetera. So again, more and more research is being done on this. I would say this slide here is one of the take-home slides. When we look at images, right, we look at DEXA scans. Some are now looking at SPECT scans, et cetera. But at the end of the day, we're looking at 3 things. We're looking at an MRI, a CAT scan, and an X-ray, and all 3 are very, very important. If you're just relying on the MRI, you're really going to lose a lot of information in terms of alignment, what happens when the patient stands, is this a cervical thoracic deformity, et cetera. And I would say, a lot of us, when we see a one-level disc disease or multi-level stenosis, sure, we get MRIs, we get X-rays, and it's a C3 to 6 Lamia fusion or some multi-level ACDF. But certainly, anytime you're starting to see some worrisome aspects in the MRI or certainly in the clinical exam, you want to make sure that you pull the trigger on the CT and the standing X-rays and sometimes flexion extension X-rays. So the MRI, I always say the MRI is going to tell you where you're going to decompress. The CT scan is going to show you where the ankylosis is, and therefore it's going to show you where the releases are and where the resections need to be. And the X-rays are for alignment purposes. You're not going to be able to measure the true alignment and certainly the alignment goals in the supine position, and that's why the x-rays are important. Not just the cervical x-rays, the complete spinal x-rays, so you know how to properly address these lesions. So again, MRIs for the decompression, CTs for the releases and the resections, and the alignment, and the x-rays are going to tell you what the ultimate correction is. Very important to study those three studies in detail. I've shown this before, and I apologize if it's a review for some of you, but again, this is, let's see if the video will play. I would say the vast majority of time we're able to do these PCOs, these facetectomies, posterior column osteotomies with relative ease in the cervical spine. Now you have to be careful if there's instability or ventral, anterior column disruption, like when we do, for example, metastatic disease or tumors, you have to put temporary rods. But here, you can see there are no temporary rods. Of course, they're just the screws and then the multiple PCOs to demonstrate that you can really mobilize the spine, the cervical spine, very nicely with PCOs, as long as you don't have ankylosis anteriorly. If you have ankylosis anteriorly, then you have to kind of go back and forth, if you will. And again, here are just some examples. This is a patient who was who healed. It's an infection that healed in kyphosis and needed a front back surgery or back front back. I don't remember what this particular one was, but basically you can see that with these anterior and posterior releases, you can get a reasonable correction. I never go for the home run here where I want to get perfect correction. These patients have been living like this for a long time. Their spinal cord is used to this. You don't want to certainly induce much traction and potentially injure the spinal cord. So I would say I usually aim for about 50 to 60% correction in many of these. And I think that's what we're able to achieve here. And actually, just a point about infections, because this comes up a lot. Why do you need to operate on infections? Of course, you don't need to operate on every infection, but especially in the cervical spine, in the mid, I would say in the subaxial cervical spine, C4, C5, C6. Once the infection, starts attacking the vertebral bodies, once you start getting kyphosis, sure, you can manage them in a collar, but you better keep a close eye on them because ultimately the infection will heal, but it can heal in kyphosis. And then it becomes a bigger problem where you need to start doing a lot of resections and releases, whereas potentially earlier on it could have been a much easier, if you will, if such a thing exists, but an easier operation, both for the patient and for the surgeon. So sure, most infections heal with antibiotics, but they tend to heal in deformity unless you kind of either keep a very close eye on them or intervene sooner. And again, I think in this case we achieved good decompression and realignment. This patient did very, very well for several years, actually. So again, front, back, front, but you really have to identify where those releases are. And this is another example again, and I'm going to show this a little bit later on, but the more adept you can get at only anterior, only posterior, you can do a lot more. I would say early on, I used to do a lot more front backs and back fronts just to get that correction that I wanted. This is a rather extreme case of post-radiation rigid kyphosis in a man in his 60s, actually. And I apologize, I don't have the long follow-up x-rays, but I followed this patient for a couple of years. He actually did really well. Again, back, front, back, where we had to do releases, put some of these standalone cages, going wherever they could, but just to achieve some of those releases. And in this case, we had to go to the occiput. Again, not perfect, but he did really well for several years. We fixed his horizontal gaze, decreased his neck pain, and he did very, very well. So you've got to be a little creative with these sometimes, but you really have to instrument long in order to get durable results. Dropped head syndrome is actually a diagnosis that I'm quite interested in. It's because, to be honest with you, if you have a lot of rigid deformities, post-radiation, post-surgical, iatrogenic, etc., the drop head syndrome, which is typically just like it is, it's iatrogenic, it's idiopathic. We don't know why it happens often. and it happens usually in younger patients, and it tends to be semi-flexible. These tend to be semi-flexible. Again, you can only, sometimes you can go front back, sometimes you can do just posterior. In this particular case, this was a younger patient that I didn't necessarily want to go front back, and I certainly took a little bit of a risk of stopping at the high thoracic spine as opposed to extending her down below to the lower thoracic, which probably, if you open a textbook, you look at this and you say, well, this is really a T, the LIV should be a T8 or T10. I took a little shortcut with her. It worked well. I followed her for years. She did really well. And you can see on the AP, when I do posterior cervical spinal deformity surgery, I really like that third rod. I like that third rod, that translaminar screw at C2, and then bring that third rod down and tie it to the high thoracic spine. I just think it adds an extra layer of rigidity, especially if you're doing all posterior. If you're doing anterior posterior, you can get away with a little bit less. But if you're going, as everybody knows, right, and this is the basic principles of trauma, we learned this from cervical spinal trauma. You can either go long, typically anterior or posterior, or you can go short anterior posterior, but you can't go short just posterior, right? That's when you have those kyphoses, so post-op kyphosis. So dropped head syndrome, really interesting pathology. We still don't know much about it, especially the idiopathic one. But these patients tend to do very well from a surgical perspective, although unfortunately sometimes they have other neurological diagnoses that are challenging to treat. And and then there's of course the non-idiopathic, the ones many of us are used to. There's degenerative deformity, but of course there is post-traumatic deformity. There's oncological deformity. This is a case from years ago. This was over 10 years actually. It's a gentleman with metastatic gastric cancer to cervical spine. We did a front back, and you can see amazing reduction. Well, the reason it's amazing reduction and amazing correction is because we got to it early. He, obviously he's not ankylosed anywhere. As you know, a lot of the patients with metastatic disease don't end up fusing regardless of what you do. But we put this patient in traction, and this is really the power of traction. Traction, cervical traction, is incredibly helpful in the cervical spine pathology, especially with deformity. It can literally mean the difference between multiple stages versus just one or two stages. So this was a patient where intraoperative traction helped tremendously. I rarely put patients in preoperative traction. I would say we used to do that a little bit more years ago. Now we rely more on intraoperative traction. Again, a front back surgery. Nowadays, I would probably use an expandable titanium cage as opposed to this Harms cage, which, by the way, obviously works very, very well. But I tend to favor expandable titanium cages nowadays. And this was an anterior posterior. You don't see the posterior screws here, but for two-level corpectomy or more, I'm always backing them up posteriorly. Now, on the flip side, you have somebody like this who's a younger patient. This was a teenage boy, had aneurysmal bone cyst of C4 here, good alignment, strong bone, young kid. He's going to do great. This was simply an anterior approach and did not need to be backed up. But again, every case is different. You have to look at the bone health. You have to look at the age of the patient, the preoperative kyphosis, the preoperative deformity. But again, oncology, and the reason I put a little plug into oncology because I do a lot of tumor surgery, and I would say I always tell folks and trainees especially that oncological deformity is very real, and especially for patients who are going to live a long time, if they have primary bone tumor, if they have very favorable type of tumors, that getting them into the proper alignment is really good for them long term. So we can't dismiss our trauma patients or our oncology patients and just say, decompress and here's some screws and rods. We really have to be thoughtful about deformity correction in those patients. Now, it's funny, I wanted to show everybody this short video, and we can talk a lot about why I went front back on this. Some people say, well, you can do a 3-level ACDF or 4-level ACDF, et cetera. But what I want to show is even when you go long here, and I put this on social media years ago, it got a lot of attention, but you could, a lot of us do C2 to T2s quite frequently for different pathologies. And this is just, I always tell patients, right? We all tell patients, most, at least 50% of our flexion extension and certainly rotation comes from C1 and C2. But I think this is the first time I captured it, for me in my practice in X-ray, whereas you can see as long as you leave OC1 and C1, C2 alone, the patient can really have significant flexion and extension, even if you do a C2 to T2. Now, they're going to lose, of course, some rotation and bending subaxially, but they're still really able to do a lot as long as you spare the OC1, C1, C2 junction. So, and again, that's why for those of us and who do a lot of C2 to T2, C2 to T2s or cervical thoracic, we know that those patients tend to be happy and they do well because you treat the pathology and they still have reasonable motion, if you will. And here in the last few slides, this is one of those infection cases where I was talking about earlier. It was done only posteriorly, and you can see the staples are in, early hardware failure. So we went back and did a very aggressive front back, went to the occiput. This patient had Parkinson's, and so we weren't really comfortable with a shorter construct. And she ended up healing really well, but just to show you the power of stage surgery, anterior, posterior, and go long posteriorly, that whatever was done here obviously was not enough, and the screws pulled right out. A few slides here on OC fusions. Luckily, we don't have to do a lot of OC fusions, but when we do, it is very important to get it right. And I picked up this picture from my phone not too long ago because OC fusions are really hard to do, right? In the sense that it's a tough area to achieve arthrodesis across. It's probably one of the few areas outside of ALIF where I do use a bone morphogenetic protein, BMP, or infuse. And I do like it at the OC junction, actually, because it is a very difficult area to fuse. But you can see you can get a very solid fusion even across the OC junction, with the right biologic and the right carpentry. When you're doing cervical spinal deformity surgery, the vast majority of time, the UIV is going to be C2. Sometimes it's C1, but it's occasionally C2. We all like the C2 vertebra, of course, because there's so many nice fixation options. There's the translaminar screw, there's the pedicle screw, there's the pars screw. You can use hooks, but I really like C2, and it can very, very nicely, especially with navigation nowadays, you can really nicely leverage the significant real estate on C2. So I joke around, I always say C2 is king because it's just such a great anchoring point as a UIV. Now, for the trainees here and for the students for training purposes, there is something called a high riding vert, which is very common. And here's an example on the right where the vertebral artery is high riding, and on the left, it's a little bit more favorable. You want to know this anatomy preoperatively, not intraoperatively, or God forbid, not when it's too late, right? So you always want to look at if you're instrumenting C2, you always want to look at where that vertebral artery is. Do I get CTs on every patient? No, I really don't, actually. A lot of times it's just an MRI and x-rays. But I still look at the parasagittal views to make sure that that vertebral artery is not high riding, because that limits the length of your pars or pedicle screw. So you've got to look at the vertebral artery anatomy very carefully. Folks ask me, when I do OCs or when I do C1 to C2, do I do CTAs all the time? And the answer is no. I do not routinely obtain CTAs or vascular studies unless there's a significant congenital deformity, congenital lesions, congenital abnormalities, congenital fusions, rotations. If the anatomy is congenitally construed, if you will, then that's when I will get CTAs. Otherwise, the MRI is going to tell you where these arteries are. In cervical spinal deformity surgery, you've got to get the alignment right. If you fuse to the occiput for whatever reason, then the alignment is not only critical, it's a matter of life. I mean, and I'll show you some examples here. You never want to fix somebody's cervical spine or occipital cervical spine in what's called a bird watcher's gaze, where they're looking up, or certainly the text gaze or the reader's gaze when they're looking down, because then they're not going to be able to breathe and swallow, etc. Very important to get that alignment right. So this is a patient in Mayfield pins, for example. You can see how tucked in they are. They have chin folds. This is not a proper OC fusion alignment. You want to relax them a little bit, get rid of the folds in the neck, and make sure their eyes are staring down. So when you release that Mayfield, this is a more proper occipital cervical fusion alignment where there's no chin folds and they're not tucked in. I've shown this before, and I think a lot of my colleagues know this trick, but let me see if I can play that video. I use the Mayfield pin, the Mayfield system just to unlock the knob, and you can easily, flex and extend as needed to get that alignment you want. You don't need to do any significant, 3 levels of degrees of motion of that Mayfield or whatever. You can just undo the knob and flex and extend to that right alignment. And that trick works really, really nice, especially if you're doing a combination surgery, Chiari decompression with OC fusion, or if you're doing a decompression first, you can flex, do the decompression, and then relax again for the fusion. And again, a lot of folks know this already. So in conclusion, I would say that the cervical spinal deformity surgery is not unlike the thoracolumbar and lumbar degen in terms of making sure you do a great history and physical exam, you get the proper indications, and then you really study the images carefully to not only to measure the deformity parameters and achieve your target goals, but to identify where the releases and the resections need to be. Releases and resections take time, blood loss, morbidity. You don't want to do them at levels you don't need to. On the flip side, if you don't do them where you do need to, you're not going to get the correction you want. So it's really important to look at that CAT scan to identify those points. You do want to instrument long. I think the cervical spine tends to be a little more forgiving with long instrumentation, especially if you're going down to the thoracic spine, as we know. Try your best to conserve OC1 and C1, C2 because, patients really rely on that for motion. And I would say, although proximal junctional PJF or PJK can happen, really when it comes to cervical spinal deformity, a lot of times we're looking at DJK and DJF, and that's because we're not going long enough. You stop at T2 when you probably really should have stopped at T4. You stop at T4 when you should have stopped at T8 or T10. But worse, you're doing a C3 to C6 or a C4 to 7 or whatever it is, and then you get into that C7 T1 junction and you don't instrument across the junction, and patients get kyphosis. Very common question, do you always cross the cervical thoracic junction? No, the answer is no. I do C3 to C6s all the time, or C2 to 5, or C2 to C6. When I'm going down to C7, that's when I either stop at C6 or cross to T1 or T2. I don't like to instrument at C7. So the answer is no, I don't always cross the junction. Again, unless there's obviously a significant deformity, you've got to go along in that case. And then finally, as a lot of you know, you want to fix early before the deformity becomes rigid. If you're starting to see some PJF or some distal, if you're starting to see some distal junctional kyphosis, distal junctional failure, fix it before it becomes rigid. A lot of times with traction on the table, you can extend down to T4, T8, or T10. But once it becomes rigid, then it becomes a more, a higher risk surgery with the PCOs or worse, a PSO or a VCR in the high thoracic spine. So you really want to fix complications early in general, but especially in cervical spinal deformity surgery. And then finally, a big thank you, again, a little shameless plug to the new book that we are very excited about that was put together with several excellent colleagues. But again, this area it's becoming a bigger part of my practice, really excited about it, and absolutely thrilled to have shared some thoughts on it. So thank you again very much. We're going to stop a little bit early today. Again, this recording will be on the YouTube channel, and really appreciate everyone signing in today and being here for this session. And we will see you next Thursday. Thanks, everyone.